Namaste. My greetings on the World Liver Day with the tagline Healthy Liver, Happy Life. Respected Dr. Ashok Chauhan sir, respected Dr. Shiv Kumar Sarin ji, revered Swamiji, who blessed us all, Dr. B.B. Rewari sahab, my esteemed and most affable teacher, Professor G.P. Talwar ji, respected Dr. N.K. Ganguly ji, dignitaries, invitees, residents, nursing colleagues and friends. It's a true honor for me to be here amongst you on a day on which we discuss, we talk about, we create pathways for awareness, and we chalk out a journey of science, clinical medicine and public health for hepatic health or liver health. I would like to congratulate our colleagues who have demonstrated unique initiatives in the CSR space and public awareness, social action space. So a big congratulations to all the esteemed teams here, East Delhi team, Indian Oil and ITC and others who have led this movement and accelerated the campaign. I take this opportunity to again congratulate the ILBS family led by Dr. Shiv Sarin for the stellar work that you have done. We are so proud of this great institution of India. You are jewel in the crown of India. Congratulations and a big applause. Sir. You are pioneer, you are leader, you show the way, and you have served the nation and the world with excellence and compassion. Thank you for doing so, and many more milestones for you to achieve, and our good wishes and support is always there for you. Thank you. Well, it's a day when few reflections on the huge challenge of liver ill health should be discussed, should be reflected upon. I consider this topic and this priority as very close to my heart. Liver and heart are close. I want to share with you what bothers us as a public health dimension of liver health, and I want us to join hands to work, including our colleagues from the corporate sector. Liver disease is a major disease within the 10 most important causes of death, starting with ischemic heart disease. So it's not one of those diseases which was on the margins for a long period of time, and perhaps its volume was relatively modest, but in today's time it is within the 10 topmost causes, and the cause mix has changed over a period of time. It starts with ischemic heart disease, goes to pulmonary causes, stroke, diarrheal disease, pneumonia, which used to be on top, and then it moves on to diabetes, chronic kidney disease and liver disease. I want to emphasize something important which is perhaps not well known, that in terms of deaths, diabetes deaths in the country are about 255,000 per annum approximately. This is global burden of disease data. Kidney deaths are about 2,23,000, so less by about 25,000. Small corrections here and there. Liver diseases, chronic liver disease in particular, the deaths are 2,17,000. So 254, 223 and 217. The point that I wish to draw your attention to is that we have so much visibility on action for diabetes, and we don't have a corresponding and well-deserved focus on kidney and liver diseases. And the reason has been that we have not presented the case optimally in public health terms, and I want us to be alert to this. Many risk factors, as Dr. Sareen always emphasizes, and he has emphasized this in his beautiful book, and congratulations, sir, for that as well, that risk factors are common, pathways are interconnected. But then at some point in time, the public health approach would change to the specifics of that area, that disease. It will be different for kidney, it will be definitely different for liver, which I will elaborate in a little bit, to a little bit extent. So we have for chronic kidney disease, chronic liver disease, cirrhosis. We have a precursor to this in a big way is the fatty liver, or NAFLD, which has found the focus in public health place. It's part and parcel of the National Non-Communicable Disease Program. This was incorporated in 2021. Pathways have been laid out, risk factors identified, screening thought about, and slowly but surely this is being escalated in our primary healthcare system through the health and wellness centers. But let's build that story further. It's my understanding that the NAFLD is responsible for about 10% of chronic liver disease. The incidence of this illness is about, well, varies between 9 to 32%, let's say about 15-18% perhaps on the average, but its contribution is 10%. So okay, we have a pathway for 10% of that chronic disease which has problems and kills and needs at some point perhaps liver transplant and so on. And often for chronic liver disease, the peak time for severe morbidity and mortality is late 40s and 50s. The families need these individuals more. And for a curious reason, perhaps obvious, 70% of CLD is males, and females are less predisposed to it. We also have regional variations with a very high burden in the eastern part of India and some of our South India and western states. So there is a regional variation. When we look at overall for the risk factors, and that's where preventive effort should go, to which Dr. Sareen has alluded to and action has been spoken about. We are looking at obesity prevention, we are looking at control of diabetes, we are looking at vaccination for hepatitis B and preventive strategies for hepatitis C such as safe blood. And we saw a disturbing case study just now that not a perfect blood transfusion led to a devastating disease in a very, very special person. Alcohol consumption, these are the risk factors. All have a preventive potential. As sir said, ये सब preventable है अगर हम करेंगे. Fair enough. So we must move in every which way to prevent these, to ensure universal coverage of children for hepatitis B, safe blood, amelioration of alcohol in multiple ways, and we saw one way of doing it today. By the way, alcohol overlaps, the map of alcohol consumption overlaps with the map of chronic liver disease for obvious reasons. And in India, average consumption of alcohol, 18-19% incidence prevalence in males and about 1.3% prevalence in female, but the average consumption of pure alcohol per annum per capita is 5 liters. That's about half a bucket full of alcohol per capita. It's there and it has to be addressed. It's an individual action and also perhaps several policy actions. So there is a profound scope for primary prevention, and we want to emphasize and we want the society to join hands for primary prevention, and the pathways for primary prevention that lead to prevention of liver disease, chronic liver disease, are actually helping in more than one way. Obesity prevents heart disease, it prevents diabetes and adverse effects of diabetes and so on. So these are common good pathways. Alcohol consumption of a low level in a society, in a household, prevents not just liver, but prevents so much of other adversity, including health adversities and psychosocial adversity. So the preventive approach with the handling the risk factors is important. It helps us in multifarious way, and surely we would like to see strong and consistent progress in that regard, although it's a challenge. But when I see action by Amity, by all of you, and other action in this area, we have hope. But I want to bring to the next best option, or shall we say next important option, which is secondary prevention. And that's where there's room for us to do work as well, and particularly from academic institutions and community health and public health stakeholders. Now, India has set up an upgraded aspirational primary healthcare system in the last 4 to 5 years. The erstwhile sub-centers and primary health centers are now called Ayushman Arogya Mandirs. It's not just change in the name, but it's also a true upgrade of the vision, the potential, the human resources, and the systems that would support a fully functional, aspirational, comprehensive primary health care. So now these are Ayushman Arogya Mandir at the sub-center level, looking after about 6 to 7,000 population, 5 to 7,000 population, has a new provider apart from an A&M and outreach workers, the ASHA workers, who have done tremendous work. And this new worker is called community health officer, who is typically a BSc graduate nurse with special training. 160,000 of them have been put in place silently. I hope it was noticed, but it perhaps not noticed as much as it should have been. Such a big workforce, health workforce, has been put in place. So this is a new provider at the cutting edge of India's healthcare system. In addition, these sub-centers, these health and wellness centers, Ayushman Arogya Mandirs, at the PSC level are led, of course, by the doctor. But all these together, 169,000 of them, have telemedicine facility. All these, some about 10,000, 11,000 of them are Ayush, and the remaining ones are the mainstream Arogya Mandirs, have more than 100 drugs, free drugs, 105 for the sub-center and 172 free drug supply for the PSC. Now, it may not be perfect, but that's where we are moving by the day. Diagnostics, 14 diagnostics for the sub-center health Ayushman Mandir, and 640 odd diagnostics for the PSC level sub-center. The point that I'm making is this is the platform where we have envisioned a pathways for secondary prevention of non-communicable chronic diseases. This is what is mandated there is screening for hypertension for all citizens above 30 years, and it's happening in its own way. It should happen more efficiently, more comprehensively, and that's the job in action. This is a place where screening annually for diabetes, for cancer cervix, breast cancer, and oral cancer. These 5 diseases, and this is the place which is the entry for the NFLD as well. But the point is, I believe that's not sufficient, because we have an opportunity to layer an additional approach for detection of early abnormality in liver function. Just as we are picking up early abnormality in blood sugar status or diabetes, right? Abnormal sugar, we start acting. High blood pressure, we start acting. Similarly, there must be an approach that despite preventive approaches, citizens are suffering early signs of chronic liver disease. That could be an enzyme assay or whatever you suggest. We must detect it. My take is perhaps you need liver enzymes to be tested. That can be layered. There could be a point of care diagnosis. Today it can be a venous sample, so be it. But the point is, we must layer screening for chronic diseases at this level of healthcare for secondary prevention, because as we heard, even if the liver gets affected, treatment works. You told us stories about that. If it if you take away the factors such as obesity or alcoholism, liver reverts. It has tremendous resilience. So secondary prevention is critically important. It's being applied to hypertension, to diabetes, and so on. And early action, early detection will change the course of lakhs of Indians if we start introducing that part as well. So my request is that apart from NAFLD as a part of primary care, we must, because that's covering only this much of the larger universe, very important. But the paradigm to undertake screening for chronic liver disease, earliest possible detection among those who have the disease, and then opening pathways for treatment, and further secondary prevention by lifestyle change as well, I should emphasize, but also drugs if need be, should be done and should be undertaken. Now the issue is, this is a concept. We would urge the academia led by ILBS to create that model. Someone created the model for hypertension screening and then further pathways. Somebody else created, or teams created, diabetes screening and then telling us how this can be taken care of in a primary care setting. We have not yet seen a model for kidney disease. We have some thoughts. We have not yet seen analogous model for liver disease. It's waiting. We're losing time, because if we postpone this aspect for another 5 years, 10 years, you can imagine it's how big that opportunity is. So ILBS with its community outreach program, with knowledge powerhouse being here, and the society being connected, and of course a larger community of liver health in our country, I appeal to you, I beg you, that please move in this direction. We need to do this earlier than later. It is the primary care approach for which the platform has been done, which will prevent us from suffering in times to come. And there is no other way. Primary prevention, done. NAFLD, done. But that's not complete. And that's the message that I bring to you. We should develop these pathways. We must demonstrate how the system works. What does it take? Demonstrate the change that you can then bring in by therapy, by lifestyle change, and even drugs. And the WHO recent report tells us that we have 11% of the viral hepatitis load. We have something like 34.5 million, 3.5 crore hepatitis prevalence with B and C, 29 million B and then 5.5 million C, and so on. We are only second to China, which of course is much higher at 83 million. The point that I am making is the risk factors are floating around. Viruses, alcoholism, fat, and so on. Primary prevention, yes. NAFLD screening, yes. But I urge you to go beyond that. My second and the last point is to first complement the journey of ILBS in liver transplantation. My information is that India needs about 25 to 30,000, has 25 to 30,000 liver failures, ultimate liver failures, potential candidates for liver transplantation. We are able to do about 1,000, and I believe 10% of that or more is being done here. A big applause. You are pioneer. My question to all of you now is, that's not sufficient. How can we make 1,000 liver transplants to become 10,000 in less than 5 years? And in 10 years, can we make it 50,000? We can do it. What is that pathway? So I urge the academia and the leaders in the space of liver disease to tell us what that pathway would be. There are issues to be done by way of law and facilitation for organ transplantation system, which has happened in recent past, and we'll push the button more. I don't want to go in that detail. So very, very emphatic work has been done in that regard. Pledging has become easy. The law is, law is quite promotive, essentially promotive in this regard. Organ transportation has been streamlined. We have SOPs from the metros, from the airline, from buses and railways and so on. So that has been sorted out. There were some bottlenecks. We are energizing NOTP. But then where is the capacity to train in liver disease. The surgery, medicine, anesthesia, ICU, and social support systems together. Can we have a vision how we can do it? So that we take number of liver transplants from 1,000 to let's say 50,000 in 10 years. Can we envision that? And India can do it. India has to do it because these are the cutting edge areas which we have to achieve to be able to be in the highest at the highest table of the world. And in that regard, this milestone for liver disease must also be achieved. I'm very honored to be here, very pleased to be here. I endorse the public health awareness for liver health that you have initiated. It's also catching children young, catching young people early is the way forward. Schools are a melting pot for learning and habits and beliefs. I'm happy that schools are being embraced. We are looking upon having a very strong school health, comprehensive school health program where 18% of India lives today and devotes time, and that's also the future of India. So indeed, very, very grateful that you have taken strong measures, very systematic, well thought out, insightful measures to reach out to the community, the schools, the adult population in every which way, but so much more should happen, and I urge you that we work together to develop a primary care model, an upgraded primary care model. In this regard, this is the need of the hour, and that's my appeal. Thank you very much. Greetings. Jai Hind.